Good afternoon and welcome to today's Live with Leadership, a conversation commemorating National HIV Vaccine Awareness Day. This webinar is being recorded and is not intended for press. We urge all participants to ask their questions throughout this session by using the Q&A function at the bottom of your screen. If you have any technical related issues, please use the chat box and someone will try to assist with your needs. I now would like to welcome Dr. Timothy Harrison to begin today's session.
Thank you, and hello, welcome to the HIV.gov Live with Leadership. I am Tim Harrison, Principal Deputy Director in the Office of Infectious Disease and HIV/AIDS Policy. And today is National HIV Vaccine Awareness Day. So I'm very excited to be here discussing the updates and the opportunities ahead of us in the area of research for an HIV vaccine. Today, I'm joined by several colleagues from the community and to the federal government. I'm going to quickly introduce them to you, and then we'll begin our conversation. First, I'd like to introduce Julie Patterson. Julie wears many hats. She is a community representative on the HIV Vaccine Trials Network Social and Behavioral Working Group. She is a partner advocate with the USA training program at AVAC, Global Advocacy for HIV Prevention. Julie also sits on the Community Advisory Board at the Cleveland AIDS Clinical Trials Unit. And on top of all of that, Julie is the director of the AIDS Funding Collaborative at the Center for Community Solutions. Yes, very many hats. I'm also joined by Dr. Carl Diefenbach. Dr. Diefenbach is the longtime director of the Division of AIDS at the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health. And I would just say on a personal note, Dr. Diefenbach, we really appreciate you often providing your time to help us learn about what's going on in research. So we thank you for always being accessible. And then last but not least, we're joined by Mr. Harold Phillips, the director of the White House Office of National AIDS Policy. For today's Live with Leadership conversation, we're going to hit on recent highlights about HIV vaccine research, but we also want to make sure we're taking questions from the audience. So please use the Q&A box below to enter your questions. And so let's get started. Let me start with you, Dr. Diefenbach. I know there's been a lot of news this year about efforts to find a vaccine for HIV. Can you please summarize where we are with HIV vaccine research for everyone?
Thanks, Tim, and it's a pleasure to be here with you today and to share where we are scientifically on our quest for an HIV vaccine. We are fortunate to live in a world where vaccines against infectious diseases are pretty commonplace. It's important to realize that for most virus infections, the human body mounts an effective and vigorous immune response that clears that infection. That is the basis of most ways that vaccines work against flu and coronavirus disease. However, that is not true for HIV. To date, around the globe, there have been 84 million people infected with HIV. And in the 40 plus years we've been studying and tracking HIV disease, there has never been a case where a person spontaneously eliminated HIV from their body. But we have made significant progress in treating and preventing HIV infections with medicines called antiretrovirals. A person living with HIV, taking the medicine prescribed by their doctor, can reduce the virus in their body to an undetectable level. Through rigorous research, it has been shown that this undetectable level of virus creates a situation where people can live a life of undetectable equals untransmittable, providing millions that achieve undetectability, a situation where they are free to love without fear. We also have made fantastic progress in HIV prevention, including daily oral pills and now injectable PrEP delivered once every 8 weeks. With all these PrEP methods, when taken as indicated, these prevent an HIV negative person from acquiring HIV once exposed. It is a really amazing feat that we have this option available for people who need PrEP. Additionally, we are and maybe a little bit unfortunately, we're really good at supporting people to begin PrEP. However, adherence and sustaining people on PrEP remain a significant challenge. So while we've made advances in prevention and treatment, we need a vaccine that will effectively and durably protect people from HIV infection without ongoing need to take medication. Our goal is to deliver a vaccine that enables people to live and love the way they want without fear of HIV. Today, I'm excited to discuss HIV vaccines because our vaccine development has reached a new frontier in recent years. We have demonstrated that we can detect, isolate, generate in the laboratory antibodies that will neutralize nearly all strains of HIV. These antibodies, referred to as broad neutralizing antibodies, or BNAbs in shorthand, serve as a beacon for our vaccine development programs. These are a beacon because we have demonstrated that using these antibodies in people can prevent acquisition of HIV when delivered via infusion. That result appeared in 2021 when we announced the results of the AMP trials that showed that VRC01, a broad neutralizing antibody developed here at the NIH by the NIAID Vaccine Research Center, when delivered by infusion once every 8 weeks, safely and prevented acquisition of HIV strains circulating in the regions of the world where this test was going on that were sensitive to that BNAb. So what we must learn to do is design immunogens to train or teach the human body to reliably make these antibodies, thereby creating essentially a universal HIV vaccine. Experts agree that we need to teach the body to make at least 3 different types of BNAbs. Is it possible? Well, I'll mention a few highlights that indicate that we are closer than we have been in the past to achieving an HIV vaccine. Also in 2021, our colleagues at the International AIDS Vaccine Initiative partnered with the Bill and Melinda Gates Foundation and in collaboration with NIAID, designed a vaccine that took the critical first step towards eliciting VRC01 antibodies in people. This early stage study showed 97% of vaccinated people developed exactly the correct predicted vaccine response. Detectable VRC01 class B cells. B cells are the cells that make immunoglobulins, the antibodies. This is a huge advance. This is the first time scientists have been able to design a vaccine to train the body to make a response with such an exquisite specificity. IAVI is now taking this result and advancing it by converting these immunogens to mRNA versions so we can figure out how to manufacture these kinds of vaccines faster and iterate our discovery process. NIAID is in a collaboration with other HIV vaccine funders and scientists through something called the Collaborative HIV Immunogen Project, or CHIP. The goal here is to expand the repertoire of immunogens in study, and ideally to get to a situation we are sharing not just information, but reagents as well, and creating a pathways to these additional immunogens that reduce redundancy, harmonize approaches, and speed the evaluation of combination of immunogens. Now, back a moment to the use of the mRNA platform. The mRNA platform is our future. What the mRNA platform allows us to do is rapidly iterate, because you can produce these quickly and easily, test the design in preclinical models and in people when needed, and rapidly advance better versions of the vaccine quite often. Now, as all of us are aware, the mRNA platform became quite famous for COVID vaccines, that were pioneered here at the NIAID VRC. It's exciting to see this technology advance to create other vaccines, such as for HIV. Also, there's recently been studies initiated on universal flu vaccines using the mRNA platform. This is going to be the central platform for evaluating and rapidly iterating our discoveries in the future. We also continue to invest in other new vaccine platforms that are generating promising results in preclinical studies. For example, in the next few months, we will launch a study of an HIV vaccine using a cytomegalovirus, or the CMV vector. CMV is a very common virus that most people in the world has been exposed to or are infected with, and it will be used to deliver vaccine contents to stimulate the human immune system. These are just a few of the examples of the impressive work being done by our colleagues all over the world to find an effective, acceptable, long-lasting HIV vaccine. My remarks wouldn't be complete without acknowledging my research colleagues, our study teams, our advocacy partners, and most importantly, the participants around the world that participate in these studies. Thanks for the opportunity, Tim.
Thank you, Carl. Thank you. There's some really great information there. And I'm sure some folks may have some questions as we proceed. I want to turn to Julie here. You're a long-term advocate and leader, and we have seen great strides in terms of prevention and treatment. But I'm wondering from your perspective, why is our efforts around vaccine research still important for communities?
Great. Thank you so much, Tim. It's wonderful to be here today. So I want to say thanks again for inviting me. I'm going to do my best to speak on behalf of a number of community advocates. And I was thinking, I wanted to start by saying I'm kind of old school. It goes back many years. When I first started in the HIV fight, it was in the early 90s, and I was based in Seattle. I worked and volunteered at a couple different AIDS service organizations. And one of the things I learned on the ground then was how important it is to respond to community and how effective community-led and community-initiated prevention is. Many of the things that were developed back in those times before we had really effective treatment, before we had all these amazing prevention tools that we have now, they were behavioral interventions, they were home parties, they were street outreach, those kinds of things that came directly from community. And I think an important lesson there that carried into my degree program in public health is the idea of options, right? Choices. People need different prevention options, different choices, depends where they live, depends on their culture. Access is a huge part of it. And right now I'm based in the city of Cleveland, working in Cuyahoga County, which I think Harold knows is one of our ending the HIV epidemic phase 1 jurisdictions, which means that we're facing some of the highest rates of new HIV infections in our area. And when we look at who's impacted, it's really young people. The vast majority of our new infections are in young people. And it's also over 75% in the Black community. Black and brown folks are most impacted in our area as well as across the US and around the world. And we also see that it's young gay men, young Black gay men, and young Black trans women who are most heavily impacted. So when we think about options, another important piece there is equity. And one of my favorite researchers over at the HVTN, the HIV Vaccine Trials Network, was talking about equity as a really important part of vaccines. And we don't always think about it that way, but when you look at one of the things Dr. Diefenbach talked about was vaccines have durability, right? So if we can get people a vaccine, it may last them a lifetime if we're lucky. Maybe you need a booster, but it's something that really has the potential to be a long-term solution. And as much as we love our long-acting prevention tools that we have now, long-acting PrEP, and we also like the user-controlled methods, right? All the different things that are out there, the vaginal ring, the daily pill, but having more options is better. And so I think it's one of the things that really drives us. And as I mentioned, I'm in Cleveland now. I'm privileged to be the director of a public-private funding partnership. We've been around for almost 30 years, and we look to community leadership. And so when folks tell us what they want, what they need, we try to listen and respond and really let them take the lead. I think it's been a lesson that we learn over and over again, not only in the HIV field, but in infectious disease prevention, and we have to listen to community. So I think there's a lot to learn there, and it keeps me involved. I'm a vaccine advocate, a prevention advocate, as you mentioned, and it keeps me involved because I'm passionate about having more options and more choices. So thanks.
No, that's wonderful, and we're so pleased that you are joining us this afternoon. I want to turn to my friend Harold, Office of National AIDS Policy. Julie referenced the term equity health equity, which I think is a good segue into talking about the focus on research that's in the National HIV Strategy, the NHAS. What do you want? What do you most want communities to know about the importance of our ongoing efforts to find an HIV vaccine and how these fit with other priorities?
Sure. Thank you, Tim. And it's great to be here with everyone. Today is not only HIV Vaccine Awareness Day, but it also marks sort of this 1-year anniversary of the Mpox outbreak in the United States. And when we think about sort of where we are today, where we have, yes, it's not over, and we've done tremendous work to scale up availability of vaccine and treatment for Mpox. It was a response that was centered with the federal government listening to the community and making adjustments as we went along, adjustments in terms of vaccine distribution and where and how and our messaging, and thinking about ways to make treatment easier from sort of those hours of pages that had to be done before to access treatment for Mpox to 15 minutes, and now an exciting clinical trial that we need individuals to learn more about to help us understand the impact of treatment for Mpox. And maybe Dr. Diefenbach can talk more about that later. But I think thinking about sort of the role that vaccine plays in our overall effort, Mpox is a great example of what we're trying to achieve when it comes to HIV and HIV vaccine research as well. The NIH-funded research is integral to achieving both the National HIV/AIDS Strategy and the Ending the HIV Epidemic goals. Those research opportunities are incorporated into our National HIV/AIDS Strategy, I think in a very, I'm proud to say, in a very comprehensive way that includes not only the search for a vaccine, but cure and also implementation science. And it's all reflective of the mission of the NIH, its institutes, its offices, and the centers. That research base for ending the HIV epidemic aligns well with the components of our National HIV/AIDS Strategy and our goals. The focus on research fills both gaps and priorities. It allows us to focus on the role of social determinants of health and quality of life for people living with HIV, and it promotes research among priority populations. I think the last thing that I will say about equity and research, we really need people of color and also women to enroll in clinical trials to help us in our search for a vaccine as we look at both effectiveness, impact on populations, and also how and what's the best way to sort of administer a vaccine when we get there. So I think Dr. Diefenbach just gave us some hope, but we also need more minority enrollment in clinical trials to help us do this work as well.
Great, thank you, Harold. And now we do have time for questions. So please, again, if you have a question, please use the Q&A function at the bottom of your screen. And perhaps I can get us started here for some additional questions. And I want to pick up on the last remarks you were making, Harold, and this is open for all three of you. Sort of looking at clinical trials now, what are the demographics of the typical HIV vaccine study participants? And do they represent the population groups most affected by HIV? And again, anyone can respond.
I think the challenge we face is the need for ongoing community education. And we saw this really reflected in the rollout of the COVID-19 vaccines, and that we had an entire group at the HVTN in Seattle dedicated to helping reach community and encouraging the enrollment. It was so critical for COVID vaccines and for HIV vaccines that we have sufficient numbers of people of all colors enrolled in our studies and genders to really understand then the effectiveness of these vaccines. We've pushed very hard for that with the Moderna. So the co-VPN was involved in several of the vaccine studies, and we are very proud of the level of recruitment that we were able to obtain. At one point, we even stopped enrollment of white people because we needed to have the right people in the study to get the answers. And that's the kind of leadership that we need, is when you get to a point where you, in order to meet your need, you actually change what you're doing in your study so that you can achieve your goal. It's not just enough to say, oh, well, we tried, but you really have to make a commitment from day one to make sure that you're educating the community, you're providing the information to the people on the boots on the ground at the sites that are enrolling, and then monitoring your enrollment so that you can achieve your goals.
Thank you. Thank you. Did anyone want to add, Julie or Harold, to that?
Yeah, I could add a little bit on that. I think one of the things too that's really important in that, Dr. Diefenbach, that you're mentioning is the role of advocates in that. I think when folks had an opportunity to see when the trials are transparent, right, the enrollment and the demographics are available and community can see that they're not representative of who's most heavily impacted, we've had a chance to have a dialogue. So with the researchers, and early on, I think that's the other thing, is when the protocols are being developed, when it's the very beginning of the design, involving advocates so that you can really think through just what you're saying. So not just we're going to open our doors, we're going to encourage people to be part of the trial, but actually doing really on the ground community preparation, meeting with key stakeholders and leaders in a given community to build trust, and working with them to understand what the trial is about and to encourage that kind of enrollment. But again, even in the midst of all that, setting the goals. Some people use the term quotas. I know the researchers don't like that. But when we think about being able to do analyses at the end of a trial, knowing that there are enough of a given population to be able to understand whether that particular intervention or tool works in some of the most heavily impacted communities, you have to have enough people enrolled. And that's been so important. And I really think that in the vaccine research, kind of the leaders, the folks, the principal investigators, the teams putting these together, it's been an important part of that dialogue, and they're really responding in a way that has made a difference, just as you said. Now we have more to do, but I think it's been the right pathway, and working with advocates has made a huge difference there. So.
Wonderful, wonderful. And just to level set here, some of the terminology, could you talk a little bit about the role of community advisory boards? What is their role, and how can people get involved if they're interested?
Can I take that one? Yeah, I'll say a little bit on it. I sit on a community advisory board. You mentioned that, Tim, at the beginning. At the local level, but also on the global level. So it's an interesting thing. Sometimes folks, the name might seem obvious, giving advice, right, to clinical trials, but in fact, it goes way beyond. As I mentioned, it's partly about engaging local communities, which we know is so important, to talk to folks about whether this trial is even acceptable in the local community. And I know in Cleveland, we've turned away trials. We've had conversations about them, and if it didn't seem like a good fit, we've turned them away. Now, not very often, but it's an important piece of that kind of shared power, if you will. Community advisory boards are open in our situation to anyone interested. It tends to be folks who are from communities that are impacted because people are joining out of a sense of I think, care for their loved ones or their own vulnerability. They're interested in HIV because they know people who've been impacted, or they themselves are living with HIV, really want to do something about it. Sometimes people will think that it's about recruiting for trials, but it's actually not. That isn't anything to do with our role. The Community Advisory Board is there, as we mentioned before, to be in dialogue with the researchers about any questions they have on working in the local community to make the trials more effective, to get better results in the end, and to be able then to bring back the successful tools to the community and have them really be welcomed and used. So, but I'm guessing, Harold, you might have something else to say too.
No, I think you did a great job, Julie, of sort of describing that role. I think one of the important things that I will lift up that you said is it's really working in partnership as we sort of figure out which clinical trials fit within which community. And it's also those individuals who are part of community advisory boards who really and truly are committed to making a difference within their communities as well. And so these are the kind of folks who get involved in the research either at the community advisory board level, including those who enroll in clinical trials too.
Great. We're having several questions on the regarding how can minority communities find out when and where trials are taking place? Where is this information?
HIV.gov, the center of the universe. And that's in some ways, that's a perfect segue, because not only can you find out about HIV trials, but also about the trials for Mpox. It's really important for people to realize that CDC, in partnership with NIAID, is changing how people will access tecovirimat, the really important antiviral for use in the Mpox disease. All the people who are seeking to acquire TPOXX will go through the STOMP trial portal. This is an important step forward because people can be screened and get drugged, drop shipped to them very rapidly. We're allowing for presumptive diagnosis and then providing the medication. So we really hope that we can speed people's healing and access to this medication as we go forward. And again, as I said, and I'll say this again, that the John Brooks at the CDC and Dimitri have really helped us get this level of engagement between our two organizations. It's a really critical step that we are ready, should there be an outbreak this spring, that we will be able to really meet the needs of the American public.
Thank you, Carl. I wonder if you mentioned the STOP trial. I don't know if Harold wanted to add any additional thing to that at this time.
I think it's really exciting and truly an evolution of how we're going to approach this. And some of it, again, as we've said on this, is based on input from the community about needing this treatment to be more accessible. And also, we've also heard from our clinical providers, too, the need to change that system. And so this is a really exciting development. The other thing that I will say as we sort of highlight and talk about vaccines is it's really important that individuals get both doses of the Mpox vaccine. So if you haven't done it, there's still time, as well as checking out CDC's website about Get Ready for Summer, so that you can check up on all of the things that may be impacting you this summer. Travel immunizations, as well as Mpox, COVID-19 information about how to protect yourself and others from overdose as well. So we definitely want everyone to enjoy the summer, but be safe. And for many of us, that means getting that second Mpox shot as well.
Excellent, excellent. It looks like we're running out of time here. So one last question, if I might. And you know, we've had the experience, as you all have mentioned, the experience with COVID recently and COVID vaccines, and the uptake was significant, but not for everyone. There are certainly attitudes out there regarding vaccines, and particularly for those communities who you've identified who really need to be invested in this issue. What would you say about, should we do have a vaccine, about the importance of the communication and the welcoming of vaccines as we move forward?
I can start and then definitely turn it over to other members of the panel. I was recently reading an article that showed that that I think since October, the death rate from COVID is higher among whites than among Black Americans at this point. And I think and the article was sort of saying that in particular areas of the country, and it may be due to the politics of public health or views about sort of the COVID-19 vaccine. But for me, it kind of like, while it shocked me, it also made me think about and reflect on the intentionality that many of us went about sort of trying to make sure, especially that communities of color and underserved populations and the homeless and those who are using substance, that they had accurate information from trusted sources about the importance of the COVID-19 vaccine. And so I think we were able to do that. So I don't buy into the fact that, you know, medical mistrust is so great that we can't overcome it within these communities, because I think the COVID experience and being intentional about addressing equity, it has shown us that we can do it in this country. And I hope when we get an HIV vaccine, we'll keep those same principles in mind.
Wonderful. And Julie, I'm going to give you the sort of last words here. Any sort of final messaging you'd like to send out?
Yeah, thank you so much. I was just thinking about what Harold said and wanted to maybe leave us thinking about at the beginning of the COVID epidemic. I know I was involved, and I think several people were in bringing lessons from HIV into our struggles with COVID. And now there's a bit of more mutuality right across. I think we can learn so much from COVID now. And also Mpox in terms of how vaccines have been rolled out. So particularly for the search for an HIV vaccine, but then the eventual success and then rollout, I think we're going to need to take lessons. And those lessons are just what Harold said. It's all about preparing communities now to accept it. We can't wait until we have something. We need to be doing that now with scientific literacy, with building trust with the medical providers and the institutions doing the research. But we also need to then kind of learn about how we have community organizations and community leaders helping us to roll out an eventual vaccine. That's going to make a world of difference in our success. So yeah, thank you so much.
Thank you. And I just want to thank all of you for joining us. And a special thank you to our special guests, Dr. Diefenbach, Julie, and Harold. Our time was brief, but it's really important messaging out there on this HIV Vaccine Awareness Day. Please visit hiv.gov for additional information about NIH research efforts. You can also find more information about the HIV Vaccine Trial Network at www.hvtn.org. And to become a volunteer and sign up to participate in an HIV vaccine trial, please visit www.helpendhiv.org. Thank you.